Dr. Rotin Sarkar, who is one of our course director, to introduce today's chairperson, Dr. Ashish Bosu, and Ashish Bosu in turn introduce Rana, and if the subject necessary. Over to Dr. Rotin Sarkar.
Thank you, Amulda, and good morning to all of you. Now, we have a very interesting topic today in today's master class, the oral anti-diabetics. Today's class will be taken by our young, erudite, and dynamic speaker, endocrinologist, who will be introduced, Rana Bhattacharjee, who will be introduced by my friend, long time from medical college, Professor Ashish Basu, who have worked in the Department of Medicine. He then became the head of the Department of Endocrinology in the Calcutta Medical College. Then he also served as the principal Calcutta Medical College. He has many publications to his career, and the topic today is oral anti-diabetic. We all know there are a lot of anti-diabetics on the pipeline now. Hello.
Sir?
Ashish.
May I start now?
Yeah. Introduce the speaker of today and the subject. A brief description of the subject.
At the outset, I profusely thank the API, the whole scientific team, for giving me this unique opportunity to share this important topic. You know, the API West Bengal branch is steering all sorts of activities and is the headline on the API domain in the all India basis. So thanks, sir, for all the API leaders, local leaders. And today the important topics is oral antidiabetic drug, the points to remember. And you know, the India is facing a tremendous challenge, formidable challenge for the upgoing incidence of the diabetic population. So we must be armed with the proper knowledge of how to tackle with this menace of diabetes. And we have a very erudite speaker, erudite Rana Bhattacharjee, erudite speaker, a lot of accolades to his credit, a lot of awards. Dr. Rana, I personally know, interviewed him during his promotional days. So Rana will take us through the important aspect of oral antidiabetic drug, the points to remember. So over to Rana, please.
Thank you, sir. Hope I am clearly audible.
Yes.
Thank you, API West Bengal branch and Indian College of Physicians West Bengal branch for this invitation. I'm really honored, and thank you, Dr. Mukherjee, Dr. Sarkar, Dr. Ghosh, all the seniors who are there. I taught a lot of medicine from all of you, sirs. So today, what I'm going to discuss is a very practical topic, and as this is mainly aimed at postgraduate students, my focus will be for their knowledge, their practice, as well as to some extent their examination. And I will discuss the special points, and to me the important special points what I thought of are the mechanism of action of each antidiabetic drug in brief, whatever is known about them, because those are again very important for their use and also for their exam. Plus, I will discuss the pros and cons of each of the drugs so that they can use it during the clinical practice properly. So to begin with, as you all know, the oral antidiabetic drugs are mainly the drugs for type 2 diabetes, although these oral drugs can be used in some other relatively rare forms of diabetes, like some drugs can be used in pancreatic diabetes, some oral drugs can be used in maturity onset diabetes of young, but mainly it's for the focus of anti-diabetic drug, the development, everything is focused on type 2 diabetes. Now, when we talk about type 2 diabetes, it's not a single disease. It's a kind of mixed bag where the various types of pathophysiologic mechanism interact, and the main determinants are genetics plus environment, both of which affect the insulin secretion as well as insulin action, plus a host of metabolic changes within our body. So that's why it's important to individualize the approach in treating diabetes, which we'll discuss as this topic goes on. Now, whenever we talk about type 2 diabetes, this is one of the very famous picture you all know about, and it's the main proponent, Ralph DiFronzo. This is from his Banting lecture back in the year 2008, and it was published in 2009 subsequently. And he proposed that beyond the simplistic design of insulin secretion and its action, type 2 diabetes affects a host of tissues and organs in our body, and which leads to hyperglycemia and its associated metabolic defects. Now, those include the defect in the beta cell of pancreas and also in the alpha cell of pancreas, where there is increase in glucagon secretion and decrease in insulin secretion. On the other hand, there is resistance of insulin in the liver, in the muscle, and in the adipose tissue, leading to increase in hepatic glucose output, reduction in post-meal glucose absorption within the muscle, and increased lipemia following a meal. The other effects are decreased incretin effect. I will discuss that while we discuss the incretin-based therapies. So this is another arm. Another part is the glucose reabsorption. In diabetes, there is increase in threshold of reabsorption of glucose. The reabsorption of glucose actually increases. So glucose threshold is increased. Therefore, more and more glucose is reabsorbed in the state of diabetes. Another important component is brain, which has multiple effect on the appetite, on the insulin secretion, and on the insulin sensitivity. It regulates many of these organs and many of these mechanisms, forming the eighth arm of this octet. Now, when we were students, we were doing our MDs, we had a very few drugs for use. We had metformin, we had some basic sulfonylureas like gliclazide, we had glipizide and glibenclamide, and we had metformin. Plus, we had some insulins. Very few options were there. Now, in the last 2 decades, there is a flurry of influx of newer and newer medications for management of diabetes, and lots of research is going on. And we now have a host of drugs that I'm going to discuss. But the problem is that with availability of so many drugs, it's often difficult to choose which one to use to which patient, how many of those to use, at which dose, and how will modify our treatment in presence of comorbidities. So that makes a decision making quite difficult sometimes. So it's very important to know the action of each drug, where it's best suited, its expected adverse effect, what are the precautions of its use, and how much is the efficacy, and what are the additional extra glycemic benefit. Now, if we know these things in detail, we can place these drugs properly during the management of diabetes. Now, coming back to the ominous octet part, which we are discussing. Now all these drugs that I have shown to you, those act on these various arms of this octet. And again, I will discuss these things while discussing individual drugs. Now, let's start with the biguanides, the most often used antidiabetic drug in type 2 diabetes. And although we say biguanides, it's for practical purpose, it's not a plural anymore. We do not have any other drug than metformin as of now for use. The other biguanide, that is fenformin, is no longer available due to its toxicity. Now, although metformin is an age-old drug, so the metformin is in use for decades, but however, the mechanism of action was not very clear, and some light has been shed on its mechanism quite recently. And one of the very important mechanism is its action on mitochondria, and to be more precise, a particular mitochondrial enzyme called glycerophosphate dehydrogenase mitochondrial variant. So what this enzyme does, it basically converts the glycerol 3-phosphate, which enters the mitochondria, and converts it to dihydroxyacetone phosphate. And what happens after this conversion, this dihydroxyacetone phosphate, it shuttles back to cytoplasm and it takes part in the formation of glucose by the mechanism of gluconeogenesis. Now, not only DHAP, also a very important component or substrate rather of gluconeogenesis is pyruvate. So both DHAP and pyruvate increases gluconeogenesis, and that contributes to increase in hepatic production of glucose and its excretion in the bloodstream. Now, what happens with inhibition of this mitochondrial variant or mitochondria specific isoform of glycerophosphate dehydrogenase? With its inhibition, as you can well imagine, the concentration of G3P increases within the mitochondria. Therefore, more of glycerol triphosphate, it remains within the cytoplasm and it's converted into glycerol and it's excreted into the bloodstream. Similarly, the lactate to pyruvate ratio also increases. So there is reduction in pyruvate and increase in lactate. And there is increase in this lactate secretion again within the bloodstream. So not only this increased lactic acid secretion, but also there is an important change is gluconeogenesis. As you can see, there is reduction of concentration of DHAP as well as pyruvate within the cytoplasm. So gluconeogenetic substances are low in concentration and therefore less glucose is excreted in plasma. So in a simple term, use of metformin by inhibiting the mitochondrial variant of glycerophosphate dehydrogenase in turn inhibits gluconeogenesis and reduction of glucose exit within the blood. Therefore, blood glucose concentration is reduced. Now, this is possibly its main mechanism of action, but it has several other ancillary metabolic mechanism as well. This picture looks complicated, but I will simplify it for you. Metformin, when it enters the cytoplasm through OCT1, it also acts on AMP kinase. And what happens by this activity of AMP kinase? There is some alteration of energy balance within the cell, and it interacts with the second messenger pathway of insulin receptor, and ultimately that leads to increase in blood to translocation in the cell surface of muscle and to some extent liver, and there is some transcription of genes which involves in energy storage and ultimately leads to increase in uptake of glucose, increase in glycogen synthesis and reduction of lipid synthesis, as well as there is reduction of gluconeogenesis, which I have already discussed. Now, why we consider metformin as a first-line agent. Whatever guideline you see of type 2 diabetes, we always talk about metformin as a first-line agent. Why it is so? It's mainly because of its glycemic efficacy. It's a very efficacious drug. It's practically weight neutral. It doesn't increase or decrease. In a small subset of patients, it leads to weight loss. But that's not universal. But in some subset, it can be quite remarkable. There is no hypoglycemia. Hypoglycemia is very minimal. But again, practically speaking, possibly we have used in thousands of our patients. We have seen very few cases of hypoglycemia when used in isolation. That's why it's used in many non-diabetic indication as well. The tolerability is generally good. The cost is low. It is one of the cheapest anti-diabetic drugs that is available to us. And possibly it has some extra glycemic benefit, although the evidence is few. Like the benefit from of cardiovascular disease regarding the lipid profile, there is small changes, and there are some data regarding its anti-cancer effect. Regarding the cardiovascular effect, we know the ICPWB study, which was mainly designed to see whether the glycemic control leads to improvement in the complication rate, because before 1997, we were not sure that using the anti-diabetic drugs, they actually improve the condition of the patient beyond controlling the symptoms of hyperglycemia. With ICPWB, we came to know that yes, good glycemic control can have long-term beneficial effect. And there are some sub-studies of this landmark study as well, and one of them actually showed that use of metformin, particularly in obese patients, because at that point of time, metformin was used in obese patients only. Now it's used in all kinds of patients. It has been shown that in those patients at least, there is some benefit in terms of cardiovascular outcome. So therefore, it can be considered as additional benefit of this drug. However, there are some concerns which we need to remember while using these drugs. GI tolerability can be an issue in some patients. So many a times we start with a lower dose and then gradually up titrate. But again, as I said, the GI tolerance is generally excellent. Second is vitamin B12 deficiency, which it has been seen that it reduces the absorption of vitamin B12 around 1/3 in the terminal ileum. And when measured, the B12 concentration was found to be low in around 5 to 10% individual. But megaloblastic anemia is extremely rare. So AD suggests that we may screen for the deficiency of B12, particularly in susceptible individuals. One of the examples is those who are on vegan diet. As we know, the proteins or whatever food that we take, which comes from plant source, is very poor of vitamin B12. So it comes from animal source, either fish, meat, poultry, or from milk. So if those are not there in the diet, the patients are more susceptible and therefore more prone to develop B12 deficiency. And a point which is often discussed, that is lactic acidosis. Practically, this complication is almost bordering to non-existent. Like when used with as per proper indication, lactic acidosis is extremely rare. It is similar to non-metformin group. So this is not a practical concern. But however, we must remember some conditions where we should not use this drug, like renal failure. And here in this context, you must know how to adjust the dose of metformin in a patient with CKD. Now, when the eGFR is more than or equal to 60%, you can use full dose. When it is between, sorry, not 60%, eGFR is 60. When it is between 45 and 60, you can continue to use the full dose, but you should monitor renal function every, say, around 6 months. When it is less than 45, that is between 30 and 45, that level of eGFR, usually we use half dose of metformin. For our practical purpose, that is 1 gram per day. If it is less than 30, then we usually do not use metformin. In hepatic failure, particularly advanced and decompensated liver failure, this drug is contraindicated. The same is true for advanced congestive cardiac failure, in sepsis, with contrast agent, particularly when the eGFR is low. So when the eGFR is less than 45 and we are using a contrast agent, like where the patient will undergo CT, contrast enhanced CT scan, which is a commonplace nowadays. So it's better either to stop metformin or to monitor renal function closely and maintain the hydration status. Surgery again is no more a contraindication, but we should stop metformin on the day before major surgery. We can continue it with minor surgery. Initially, we used to stop it 48 hours before surgery, but it seems no longer necessary. Now, the next group of drugs are secretagogues. Now, in secretagogues, we have two major classes. One is sulfonylurea, another is meglitinides. Sulfonylureas are glibenclamide, glipizide, which are older drugs, and relatively newer drugs are gliclazide and glimepiride. All those drugs are available for use in India. The second class of agent, that is ripaglinide, again, which is available, and nateglinide. These glinides have a very short half-life, so they mainly act on postprandial blood glucose level. How does this secretagogue act? Basically, to know how does this drug act, you must know the how glucose stimulates the secretion of insulin from beta cell. Now, once glucose enters the beta cell via GLUT2, now this is one of the transporter that is non-energy dependent. So glucose is transported within the cell by a concentration dependent manner. That means when the blood glucose concentration is increased, more glucose enters the beta cell. And what happens there? By the action of glucokinase, which is there within the cell, glucose is converted to glucose 6-phosphate. And you know, the one of the pathway by which glucose 6-phosphate is metabolized is via glycolysis, which subsequently via Krebs cycle within the mitochondria forms a lot of ATP. This ATP acts on ATP sensitive potassium channel. Now, this is the channel which causes leakage of potassium from the cell. Now, once this channel closes, there is increase of potassium within the cell, and this leads to depolarization, which leads to opening of voltage-gated calcium channels. And these voltage-gated calcium channel, once it opens, as you know, the concentration of calcium is very high in extracellular fluid. So a lot of calcium enters the cytoplasm. And this calcium leads to the translocation of granules, which contains insulin from the cytoplasm to the cell membrane, and it fuses with the cell membrane and releases the insulin. Not only that, this calcium also increases the transcription of glucose, of insulin. So more insulin is produced and more insulin is secreted. Now, where does sulfonylurea come into this picture? Sulfonylurea is basically, sulfonylurea or meglitinides are the molecules which basically short circuits this whole pathway. What it does, it directly binds with the ACOR1 component of the ATP dependent potassium channel. So it binds with that and closes the potassium channel forcefully. Even if the glucose concentration is very low within the cell, it directly closes the potassium channel and leading to the cascade of events that ultimately leads to excitosis of insulin and therefore release of insulin. And this is why the hypoglycemia is so common in not so common, rather it's seen with sulfonylurea, because it acts in a glucose independent manner. This is the term you will often hear, And this is the actual mechanism. Now, where we use it? Usually as an add-on to metformin. It's a first-line drug when the metformin is contraindicated or internal to type 2 diabetes. But now we have other first-line options as well. When there is hyperglycemia is relatively severe, then we tend to use this drug when insulin is not indicated per se, when it's not very high and patient doesn't have any symptom of ketosis or osmotic symptom. Then basically this hypoglycemia, this in presence of relatively more severe hyperglycemia, this group of drugs seems quite useful because they can reduce blood glucose level very rapidly. And in addition, as I was discussing, that it can be used in other forms of diabetes as well, like some cases of maturity onset diabetes young, some cases of neonatal diabetes mellitus, and even some cases of pancreatic diabetes like FCPD. Now, what are the concerns? Hypoglycemia and weight gain are the two major concerns. Okay, hypoglycemia is the most common side effect, and it's less with lesser newer generation sulfonylureas. And the risk increases with the common factors like after unaccustomed exercise, after one misses a particular meal after taking sulfonylurea, we are using a high dose of sulfonylurea than required, associated alcohol abuse, associated renal impairment, which increases the metabolic stay of these drugs and their metabolites, a patient who is hospitalized with critical illness, and co-administration with some drugs like sulfonamide, salicylate, or warfarin, which can displace the binding of sulfonylurea from the protein. Okay, so these causes increase in risk of hypoglycemia with sulfonylureas. Now, one of the concerns possibly many of you have heard regarding the cardiovascular adverse event, and basically it originated a long ago by a study called UGDP project. And this particular project showed that a higher rate of cardiovascular death, patient who used tolbutamide, it was one of the drugs that was used in the past, it's no longer available. But there were several studies subsequently, and even there are some reanalysis of this particular trial which showed that in reality, this UGDP project has had many pitfalls and the results are not valid. Moreover, with the newer sulfonylureas, which has a different mode of action, they actually possibly do not cause any adverse cardiovascular event. And one of the mechanisms which has been proposed for this is the effect on ischemic preconditioning. Now, what is ischemic preconditioning? It's a kind of adaptive mechanism where the milder degree of ischemia protects the heart from subsequent more severe insult of cardiac ischemia. So preventing the myocardium or protecting the myocardium from the low blood supply. Now, one of the important mechanisms for this ischemic preconditioning is the potassium channels. And in cardiac cell, the similar kind of channel is present just like the beta cell, but with some differences. In this beta cell group, Dr. Pathak, I think your marker or something has been activated. So there are many marks are visible on the screen. Sir, can you please kind of quit that particular part, the marking part, as you can see in the left cornermost, lower left corner of your panel, sir. You can just deselect it. So coming back to the topic, so what happens with the newer sulfonylurea like gliclazide? It basically does not have a moiety which actually blocks the potassium channel within the myocardium. And drugs like glimepiride also have a very kind of transient action on these channels. So they practically do not impair the ischemic preconditioning. Therefore, there is no adverse effect on myocardium. And there are multiple studies has been published till date. One is ICPWB, where it has been seen that there is no difference in mortality. And another large group of studies, one of them is advanced study where gliclazide is used. It has been seen that in an intensive group, there is no adverse cardiovascular event. And one of the traditional CVOT trial, cardiovascular outcome trial called Carolina, where linagliptin was used vis-a-vis glimepiride, and it has been seen that there is no additional cardiovascular adverse event of glimepiride, even in a patient who has a high risk of cardiovascular disease. So overall, we can say the cardiovascular safety of the newer sulfonylureas are established now. So we can use this drug in a patient who has established cardiovascular disease. Now, coming back to few of the practical points, how we should use these drugs. Now, mainly it concerns the kidney. In case of glipizide and gliclazide, usually the major mode of excretion is not kidneys. Therefore, they can be used in a patient with CKD stage up to 3. Whereas we should avoid glibenclamide because one of the active metabolite of glibenclamide tend to accumulate in a patient with renal failure, thereby increases the chance of hypoglycemia. And glimepiride, we either can avoid or we can use the low doses in a patient with CKD. Ripaglinide usually doesn't need any dose reduction up to eGFR of 20. Below that, the data is scant. Nataglinide is not available in the country, so I won't go into this discussion. The third important class of so-called older molecule now, because it's been there in the Indian market for quite some time, and how these drugs act. Now, unlike the other drugs I have described, here these drugs acts mainly on nucleus. So it acts on PPAR gamma, which is a transcription factor, and it increases or enhances the action of PPAR gamma, and it leads to the transcription of a range of protein which can have wide range of metabolic action within our body. It promotes adipogenesis, it improves insulin resistance, and it improves hepatic insulin sensitivity to some extent. Now, what happens when we take a meal? Now, this is very important to understand the effect of pioglitazone or rosiglitazone where it is available. Now, when we take a carbohydrate, as for example, if we take around 100 grams of carbohydrate, there are some mechanisms by which it is buffered. There is rapid entry of glucose within the cells, particularly the muscle cell. And this is enhanced by the effect of insulin. Now, if this action is not there, the blood glucose level would have risen 8-fold. So you can just imagine that how much rise it is. So a person who has a baseline, say, blood glucose level of 90, the blood glucose level will become, just after a minute, it will become 700. So it's a scary situation. So for that reason, the insulin seems to be very important. And what does insulin do? In liver, it switches off glucose production by the mechanism I've already discussed. In the skeletal muscle, it enhances the glucose absorption under the influence of insulin. So it enhances the muscles take up more and more glucose by the transfer of GLUT4. It's a very important transporter in the muscle to the surface of the myocytes, through which the glucose enters the muscle cells. Similarly, with lipids, there is buffering within the adipose tissue. If this buffering is not there, the triglyceride level could rise also manifold. Now, how this buffering of lipid occurs within our body? The insulin stimulates and a very important enzyme called lipoprotein lipase. It breaks down triglyceride, which forms a fatty acid. Fatty acid enters the cell and again combines with glycerol to form triacylglycerol. On the other hand, insulin also inhibits a very important enzyme called hormone-sensitive lipase. This hormone-sensitive lipase has an opposite action. It breaks down triacylglycerol to fatty acid, and more fatty acid is released in the plasma. So insulin inhibits hormone-sensitive lipase and it stimulates lipoprotein lipase with a net effect of reduction of plasma triglyceride and free fatty acid and increased concentration or deposition of triacylglycerol within the adipose tissue. Okay, but the important thing is that it may seem that pioglitazone will increase the body fat and will have adverse effect, but interestingly, it actually causes the deposition of fat in so-called good location, which does not have adverse metabolic effect, like the fat deposition in lower half of body, fat deposition in the subcutaneous space, and there is reduction of muscle fat as well as reduction of visceral tissue fat. So therefore, it improves the metabolic profile by redistribution of fat. Now, what are the advantages of using this drug? These drugs are moderately effective. It improves insulin sensitivity. There are some data regarding increased secretion of insulin, but those are not convincing. For your exam purpose, you can say it improves insulin sensitivity. That's it. In which tissue? Mainly in the muscle as well as in the adipocytes. It improves some of the lipid profile, particularly pioglitazone, and diabetes prevention studies has also been done with these agents like tripod, dream, or act now, and it has been seen to causes prevention of progression from prediabetes to overdiabetes. What are the concerns? It can lead to weight gain, and weight gain is due to two factors. One, it's due to the increase in fat within our body, as I've said, the adipogenesis, although these are in relatively good location, but again, it increases the body weight. And number two, it causes fluid retention, salt and fluid retention. So we have to be cautious in a patient with heart failure. It also converts it also preferentially forms the pro-adipogenic cells. You know, the osteoblastic cells and the lipid cell, they have a common progenitor. Now, what does pioglitazone do? It preferentially shifts this formation of cells to the lineage of adipocytes. So pre-adipocyte and adipocytes are formed more, and osteoblastic cells are formed less. Therefore, it can increase the risk of fracture in a susceptible individual, like a person with past history of fracture, like a frail old lady. So there we have to be cautious. Also, in a patient with macular edema, it can potentially increase it, so we should avoid using these drugs. Hepatotoxicity practically is not there. It was a concern with the initial glitazone, that was troglitazone, and that was subsequently discontinued. But with newer drugs, basically, the hepatotoxicity is no more an issue. Rather, in a patient with steatosis, this is one of the drugs that can reduce the inflammation within the cells, and it can reduce the enzyme, the elevated liver enzymes. There is another concern with bladder cancer, for which it was banned for a period of just 1 or 1.5 months, around 10 years back. But again, the ban was revoked within this very short period, because it became apparent that bladder cancer is possibly not common in India, and there is no convincing evidence of its rise. But still, it's prudent to avoid these drugs who had a history of bladder cancer. There, it should not be used. And if there is history of unexplained hematuria, unless the patient is being investigated and bladder cancer is ruled out, then these drugs should, until then, these drugs should not be used. Regarding cardiovascular effect, there was a huge uproar back in 2008 when a trial called RECORD trial showed that there is increase in fatal and non-fatal heart disease with the use of rosiglitazone, and subsequently this drug has been banned. And a very landmark thing that happened, that in this year the FDA proposed that all new antidiabetic drugs should be tested on a person who has a very high risk of cardiovascular event, and we call these trials CVOT, or cardiovascular outcome trials. You know, now the CVOTs are quite a commonplace, and many CVOTs have been performed in the past 10 years, past 15 years or so, from 2008 to till date. And we got many informations from those trials, but those are some pitfalls as well. Today is not a day to discuss all these things, but actually this is the trial which actually prompted US FDA to announce the need for cardiovascular outcome trials. But however, paradoxically, subsequent reanalysis of this trial showed that there were some methodological flaws, and it is not that bad after all. So in US, rosiglitazone is available again, but in India, the ban on rosiglitazone still there. Pioglitazone, there was no concern for MI. Rather, it has been shown to improve the secondary endpoints like all-cause mortality and stroke in a trial called PROACTIVE trial. And recently published IRIS trial, it also showed that in a patient with prediabetes, the use of these drugs actually leads to reduction of incidence of stroke. So atherosclerotic cardiovascular disease is no longer a concern with these drugs. But however, as I said, that we must be cautious regarding heart failure. So these drugs should be avoided in a patient with heart failure, particularly so in NYHA class 3 and 4. But even with a milder heart failure, we usually avoid these drugs nowadays because we now have many antidiabetic drugs in our armamentarium. Lobeglitazone, possibly you have heard about these drugs. This has been newly introduced just a few months back in India. The standard dose of pioglitazone, as you know, is 15 milligram to 45 milligrams, but sometimes we do use 7.5 milligrams as well. In contrast, lobeglitazone is a more potent molecule, so the dose is around 0.5 milligram once a day. The efficacy is similar to pioglitazone, but due to its increased potency, the dose requirement is less. Okay, it is mainly metabolized in liver, so the bladder is not exposed. So whatever the putative risk of bladder cancer with pioglitazone, it's possibly not there with lobeglitazone. I'm sorry for this typo. It should read as lobeglitazone, not lobeglitazone. And in a patient with mild to moderate hepatic impairment or renal impairment, there is no need for dose adjustment. The same is true for pioglitazone, where unless there is fluid retention in CKD, pioglitazone can be used in a patient even with advanced CKD. Okay, so this is a new drug. The evidence is not that marked, and it has some putative benefit, but our experience is much more with pioglitazone. Now, shifting to another very important class of drugs called gliptin. The more traditional name of it is the dipeptidyl peptidase 4 inhibitor, and why it's called so, I'll discuss after one or two basic slides. Now, before discussing D4 inhibitors and another class of drugs that is GLP-1 analog, let's understand what is incretin effect. Now, it is one of the effects that has been demonstrated back in 80s by a very elegant study done on volunteers. And it has been shown that in these volunteers, on the one hand, the oral glucose load was given and the insulin concentration was measured. In those patients, after that, an IV glucose infusion was given, and it was given in such a rate that it matches the concentration that was achieved with oral glucose load. So they can be compared. What interesting thing has been observed that with a similar degree of blood glucose level, the secretion of insulin was much higher with the oral load vis-a-vis the IV route. Now, what the common wisdom say that I have shown you the picture that more and more glucose enters the cytoplasm, more insulin is released. I have described the mechanism. So, how does it matter that whether the glucose is coming from gut or it's coming from the IV line? Blood glucose concentration remains same in both of these situations, but this gap was very interesting, and this is called incretin effect. And why it is so? It is because the oral glucose load causes secretion of incretins, that is GIP-1 and GLP-1 from the intestine, which leads to improvement of insulin secretion. I will come to that mechanism. But in type 2 diabetes, what happens? This response is blunted. So you can see the gap between oral and IV glucose load is less. So what's the consequence? The blood glucose level remains relatively higher, or in other words, the insulin secretion remains relatively blunted an oral feed. Okay. And it has been estimated that after typically a standard meal, the incretin effect accounts for around 50 to 70% of insulin release. And the major incretin, that is GLP-1, is mainly secreted from the L cells present in the distal ileum and a proximal part of colon, from where it enters the portal circulation and it reaches pancreas. Now, what happens? Once it enters the circulation, it acts on various tissues other than pancreas. It acts on brain, causing reduced appetite. It acts on adipose tissue, causes increase in storage of fat. It causes the increased uptake of glucagon. In stomach, it causes increase in gastric emptying. There are some evidence that it may act on kidney, heart, skeletal muscle, and liver, but the evidence is relatively less. Now, what happens to pancreas? Now, you can see once the GLP concentration and GIP concentration is increased in circulation, it goes to pancreas. It acts on both beta cell and alpha cell. From beta cell, it increases the secretion of insulin, causing increase in glucose uptake. Whereas in alpha cells, it causes reduction of the production of glucagon. So hyperglucophonemia is counteracted. Both these actually leads to the reduction in blood glucose level. Now, what happens in the physiologic state? This GLP-1 is rapidly degraded by an enzyme called dipeptidyl peptidase 4 or DPP4. And this enzyme rapidly inactivates by snipping off the terminal 2 amino acids from the GLP-1 and GIP molecules. therefore leads to its inactivation. Now, with the introduction of DP4 inhibitors, which inhibit this enzyme, the post-meal concentration of GLP-1 increases in circulation. Therefore, more action occurs in the beta cell and therefore causes more secretion of insulin and more action on alpha cell, causing reduction of glucagon secretion. This is the main mode of action of DP4 inhibitors. Now here I will like to just add that when we discuss the GLP-1 analog, the GLP-1 analogs are designed in such a way that it prevents the degradation by DPP4 enzymes. So therefore, again, it acts on beta cell, alpha cell, and other cells in the body, as I've said. So these two therapies, that is DP4 inhibitors and GLP-1 analogs, together are considered as the incretin based therapies. Those are incretin mimetics, and DP4 inhibitors are causes the increased concentration of native GLP-1. Now, again, we have heard multiple times that this class of drugs, they causes the glucose dependent mode of insulin secretion. Now, what is that? Unlike sulfonylurea, where there is a short circuiting, where the sulfonylurea directly binds with the potassium ATPase channel, causing release of insulin. Here, in case of incretin, the mechanism is a bit different. It's a kind of indirect effect. This picture looks very complicated, but I will simplify it to you. This is the standard mechanism I've already discussed, that glucose entering through GLUT2, causing increase in intercellular ATP, leading to closure of this channel. So this is the physiological mode, and here there is short circuit by sulfonylureas. But what happens to what happens with incretins? Now, whether it's increased physical concentration of GLP-1, or it's an incretin mimetic that has been used, which is more potent and which has longer half-life, they bind to this receptor called GLP-1 receptor, and it basically converts ATP to CAM, and the cyclic AMP, it further downstream leads to the release of calcium from endoplasmic reticulum via protein kinase A. And again, as you can remember, the increase in intracellular concentration of calcium by any means causes secretion of insulin. In physiological mode and with the use of sulfonylurea, the main mode of entry of calcium is from extracellular space via this voltage-dependent calcium channel, whereas here the main mechanism is from the release of this calcium from the endoplasmic reticulum. But a question should come to your mind that by whatever way, if the calcium is released, then it will increase the secretion of insulin. So why it is not short-circuiting the pathway like sulfonylureas? The reason being, this pathway, as I've said, it depends on CAM, cyclic AMP, and it's converted from ATP. So if the blood glucose level is low, the ATP concentration is also low, and therefore the available ATP is, as it is low, despite the signaling of GLP-1, the CAM cannot generate. So therefore, there is no increase in insulin secretion, and that's why there is less or no chance of hypoglycemia with use of incretin mimetics and other DP4 inhibitors, whereas it's more common with the drugs like sulfonylurea, which short circuits this mechanism. If you have some doubt regarding this, we can discuss this again at the end of this class. Now, what are the advantages? The DP4 inhibitors are moderately effective, they are mostly safe, there is no hypoglycemia, and it's weight neutral. There are some concerns regarding effect of immune function because DPP4, besides DPP4, other dipeptidyl peptidase system, their all over the body. And if the specificity of this drug is less, they can impair some of the immune function. In fact, it has shown to increase the nasopharyngitis and cough in some individuals, but again, overall, gross immune dysfunction has not been observed. Regarding pancreatitis, there is very insufficient data of causal relationship, but still we do not use this drug in a patient who already has idiopathic pancreatitis. A very rare patient on gliptin can have skin rashes, particularly if a person develops bullous rashes like your pemphigoid like rashes. Be very careful, and it's better think about discontinuing this class of drug to see whether those get resolved or not. Similarly, hepatic dysfunction may be a concern with vildagliptin, but again, it's very rare, and vildagliptin may not be used when the SGLT level is more than 3 to 5 times than the upper normal limit. Another concern may be, or another very rare side effect can be acute joint pain, which can be seen with gliptins. This class of drug have a wealth of cardiovascular safety trial because they have come after 2008, and all of these drugs seems to be quite safe from the cardiovascular end. Regarding a few practical point of using these drugs, these drugs can be used in a patient with hepatic or renal impairment in general, but you must know that how to adjust the doses of these drugs. Now, first talking about the renal impairment. The drugs like linagliptin, teneligliptin, and evogliptin does not need any dose reduction even up to the severe CKD, that is up to the stage of end-stage kidney disease. Whereas the drugs like alogliptin, vildagliptin, sitagliptin, and saxagliptin need some dose reduction. Like when the eGFR is between 25 and 50, that is moderate renal failure, the alogliptin dose should be reduced by 50%, that is 12.5 can be used. For vilda, it is 50 milligram OD instead of 50 BD. For saxa, it's 2.5 instead of 5 milligrams. For sita, it's 50 milligram instead of 100 milligram. If the renal function is severely depressed, that is, if the eGFR is less than 30, then there should be 75% dose reduction of alogliptin, that is 5 milligram is used. Whereas if the eGFR is less than 25, the vilda can be still used once a day. Saxa can be still used in the same dose of 2.5 milligrams once a day. But sitagliptin needs further reduction of dose, and now the dose becomes 25 milligrams OD. Okay. Now, what about hepatic impairment? In mild to moderate impairment, all the drugs can be used other than vildagliptin. With a severe hepatic impairment, practically no drug can be used. There is one small study with linagliptin, but again, mostly in a patient with severe hepatic impairment, insulin is the preferred agent. From cardiovascular safety endpoint, I have already discussed. And regarding US FDA approval, there is, I have already discussed that the drugs which underwent CVOT, they have the approval by US FDA, not others. Now, coming to the SGLT2 inhibitors. Just can I take a break of 30 seconds, please? Just the transporters like SGLT2 as well as SGLT1, and the proportion of the SGLT2 contribution is around 90%, whereas for SGLT1 it's just 10%. And what happens in presence of diabetes? There is increased concentration of SGLT2 and SGLT1, and therefore the increased reabsorption of glucose occurs. And what happens with the use of SGLT2 inhibitors? By blocking this transporter, it basically causes more glucosuria and less glucose absorption. So in effect, the blood glucose concentration is reduced, whereas more glucose is excreted in urine. So if we talk about the direct effect, it basically reduces the renal threshold. So more and more glucose is excreted through urine. But it has some additional benefit as well. Now, in diabetes, we have heard that diabetes causes more retention of salt and water. Why it is so? Because if SGLT2 inhibitor increases in number, more glucose is reabsorbed and it absorbs sodium as well. And therefore, the distal delivery of sodium is reduced in the tubular fluid, which by a mechanism of the tubuloglomerular feedback dilates the afferent arterioles, and therefore more blood flow occurs. And due to this increased glomerular pressure, the further stress occurs on the kidney and the nephron gets damaged progressively. Now, what happens with the use of this class of drugs, that is SGLT2 inhibitors? The distal sodium delivery increases and it leads to the reversal of the effect of tubuloglomerular feedback, leading to the afferent arteriolar vasoconstriction. And therefore, the glomerulus is protected over the long term. In addition, there are various effects on cardiovascular system. I won't go into detail, but the overall function is the reduction of heart failure and some improvement of the pumping function, plus there is some improvement of hematocrit. So all of these tend to improve the cardiovascular function. But there are some extra glycemic benefit of these drugs as well, because it reduces the salt reabsorption, it reduces SBP, systolic blood pressure, it promotes weight loss due to glucosuria, it has some cardiovascular effect on heart failure and associated cardiovascular disease by the mechanisms that I've said. There are some renal protection because of constriction of afferent arteriole. But there are some concerns with these drugs as well. It can increase the genital mycotic infection. It can increases UTI. It can causes hypotension in a susceptible individual, and in a patients who are prone to volume depletion, it can even lead to AKI. Fracture data is kind of controversial, but in a very elderly patient and frail patient, it can causes fall. It can give rise to euglycemic decay, particularly if it is used in a patient who has a low insulin reserve. With use of canagliflozin, the increasing chance of distal amputation has been shown in CANVAS trial, but subsequently this has been shown that they are overall safe and they do not really increase the chance of amputation. But there are some contraindication and precautions, like use in type 1 diabetes, although several studies are going on now, but the risk still kind of overbalances the benefit. So it's a contraindication till date. The EGFR less than 30 is a bit older kind of thing that is still there, of course, in our permission, which is given by Government of India by DCGI. But now the studies are there which can protect kidneys even up to when the EGFR is up to 25 or even 30. But as of now, we should not start this drug when the EGFR is less than 30. Acute severe illness, ongoing UTI, ongoing vulvogenitis, in high risk of acute kidney injury and frailty are also relative contraindication of using these drugs. Now, how to advise this patient to avoid these side effects? Like the assessment of status and renal function should be done when you are starting these agents. You should assess whether the patient has increased risk of falls and fractures and also AKI. And you should advise the patient regarding genital hygiene and adequate fluid intake, so the volume depletion is counteracted. The next class of drug is alpha glucosidase inhibitor, and the drugs that are used in India are acarbose, meglitol, and voglibose. How these drugs act? They act on the microvillus where the enzyme that alpha glucosidase they decide, which breaks down oligosaccharide and disaccharides to monosaccharides and leading to its subsequent absorption. And this class of drugs, it blocks this alpha glucosidase, leading to the flatter glucose absorption profile due to the slowing of breakdown of this complex carbohydrate to simple glucose for absorption, and therefore postprandial hyperglycemia is reduced. Their A1C reduction is around 0.5%, but in Indians, as we consume a high amount of carbohydrate, their efficacy seems to be a bit higher than that is reported in the Western population. Usually, we start with a lower dose, like the voglibose dose of 0.2 milligrams with 1 to 3 meals, and with acarbose around 50 milligrams from 1 to 3 meals, and then we can gradually uptitrate to the acarbose dose of 100 milligrams thrice a day or voglibose dose of 0.3 milligram thrice a day. There are some caution and contraindication like inflammatory bowel disease, elevated liver enzyme, and the creatinine more than 2 milligram per deciliter is actually a contraindication for acarbose because it potentially leads to some accumulation of metabolites which are hepatotoxic. The newest agent that has been approved in India is imeglimin. It's said to act through mitochondria like metformin, but the mechanism of action, how it really acts, is not yet very clear. It is said to improve the beta cell function as well as it enhances the insulin action. So it's one of the molecule which basically acts in both this perspective, like enhancement of insulin secretion as well as its action. And it acts via the effect on mitochondria. It says that it partially inhibits the complex 1 of electron transfer chain, and it restores the complex 3 function which may be impaired in diabetes, and therefore it causes these beneficial effects. The finer details are not very clear till date. We hope that just like metformin, that it took around 60 years to understand its mechanism of action, we'll understand the action of this drug in more detail in the coming years. How to use this drug? We use this drug usually as a second or third or fourth line agent, but if you use in addition to any other WADs, the dose is relatively fixed, that it is 1000 milligrams twice a day. When the EGFR is low, that is less than 45 but still more than 15, the dose is 500 milligram twice a day. If the EGFR is less than 15, it's 500 milligram once a day. Now, in what patient population is particularly suited? Like a person who is intolerant to metformin. There we can use this drug, although this drug can also be used on top of metformin. Now, the last drug that we'll discuss in detail is oral semaglutide. Now, what is semaglutide? It is a GLP-1 receptor agonist. Till now, we have GLP-1 receptor agonists which basically were injectable preparation. This is the first GLP-1 agonist that is available as an oral preparation. Now, I won't go into the detail of the mechanism, how it has been converted so that it has been used in a fashion that can be absorbed orally. But the semaglutide is a drug where there is some substitution of DPP-4 molecule, which leads to its increased stay in the plasma. And this drug can be used both as an injectable preparation, which is yet to be available in India, and in oral preparation, which has become available in India. It also has a fatty acid spacer. Now, it's basically in oral preparation, it has been combined with a molecule called SNAC, that is sodium N8,2 hydroxybenzoyl aminocapridate. What this SNAC does, it protects the semaglutide from breakdown by gastric enzyme, because any peptide, they are very prone to degradation within the stomach due to its acidity and subsequently by the pancreatic juices. But this snack, what it does in stomach, it protects semaglutide from the breakdown by gastric enzymes, plus it allows semaglutide to be absorbed from the stomach itself. So it actually causes, the snack causes the localized absorption of semaglutide across gastric mucosa. So it can be considered as an absorption enhancer. And via the transcellular pathways, the semaglutide enters the bloodstream and it reaches the various target organs and it acts. So how to use it practically? The starting dose is typically 3 milligrams once a day. Then the dose is maintained with 7 milligrams once a day. And if patient can tolerate it, the doses can be up-titrated to 14 milligrams once a day. And the typically drug should be taken in an empty stomach with 120 milliliter of water. And at least after 30 minutes, one can take a meal. So one should wait for at least 30 minutes till breakfast. Okay. So after that, you can take other medicines. So this is the way semaglutide is used. And it doesn't need any dose adjustment in elderly patients. In a patient with mild to moderate hepatic impairment, there is no dose adjustment, but again, like other drugs, data is scarce in patients with severe hepatic impairment, and patients with upper gastrointestinal disease who are more prone to vomiting and all, you have to use it with caution. Now, this GLP analog is a highly efficacious drug. It reduces the blood glucose level quite markedly, and it has some positive effect on body weight loss. For the sake of time, I won't discuss the other drugs which have been used but not very popular nowadays, like cholecervolum, which is a bile acid sequestrant which acts on liver, on bromocriptine, which actually acts in brain, and HCQS, which actually by its anti-inflammatory property, as well as by reducing the degradation of glucose, have positive impact on blood glucose level. So I won't go into detail of this because these drugs are no longer that popular. So if we summarize the various oral antidiabetic drugs, metformin seems to be effective, safe, weight neutral, there is no hypoglycemia, and in CV benefit, at least in obese individuals. But there are some issues with GI tolerance and lactic acidosis, which is very, very, very rare. Insulin secretagogues can have potential for weight gain to some extent and hypoglycemia, but those are very effective drugs. Thiazolidine, again, very effective, improve insulin resistance. There are some possible benefits in atherosclerotic cardiovascular disease and stroke, but there are adverse events like weight gain, fracture, doubtful effect on bladder cancer. In a patient with macular edema, we should not use that. And of course, in a patient with the fluid overload state and a patient with heart failure, this is a real concern. Gliptins are moderately effective. It's weight neutral. It's CV safe. It can be used in a wide range of patients, including the elderly individuals. There is a putative risk of pancreatitis, but again, it possibly do not increase the risk of pancreatitis in a patient with diabetes, but in a patient with known pancreatitis, you should avoid it. There is a rare risk of rash and arthritis. Regarding SGLT2 inhibitors, those are very effective drug. It promotes weight loss. It doesn't cause hypoglycemia. It has data regarding CV and kidney protection in some groups. It reduces heart failure quite remarkably. Even it can be used for protection of heart and kidney in a patient who doesn't have diabetes. However, there is a chance of genital mycotic infection, lower UTIs, euglycemic decay, and acute kidney disease in some individuals. AGI is relatively safe. It is modestly effective, but GI tolerance can be an issue. So again, like metformin, we should start low and go slow. Imeglimin seems to be effective. It's quite well tolerated, but data are very scanty now. Oral semaglutide is highly effective, CV safe, causes some weight loss, but those drugs are costly, and again, they can cause GI intolerance, again needing gradual up titration. So, after knowing all these mechanisms, we should use this drug appropriately in an individual, but that's a topic of another day. Overall, we can say we can assess the profile of a patient as a whole regarding underlying atherosclerotic cardiovascular disease, presence of heart failure, presence of chronic kidney disease, where we can preferably use drugs like SGLT2 inhibitors or GLP-1 analogs preferentially. Whereas in other patients, we can use the drugs depending on the cost concern, depending on the end organ damage, and depending on the comorbidities. But overall, metformin remains the first-line agent in all those classes. And as a second, third, or fourth agent, we can use other drugs subsequently. So to conclude, the choice of oral drugs have expanded beyond our imagination, and the therapeutic decision is based on patient characteristics. And it's very important to recognize the potential, the limitation, and concern of individual agents so that we can use this drug effectively in our clinical practice. So thank you for your patient attention, and I'll be glad to answer any question if you have. Over to our chairperson, sir, for further comments.
Thank you, Dr. Rana Bhattacharjee, for
Yes.
your very exclusive and vivid description of the subject assigned to you. Before I open the talk of interaction, I have just few points. And among the oral secretagogue, epaglinide has some important aspect because it only stimulates in presence of glucose. So if there is no food, no stimulation, and in the hectic lifestyle cases or in the Ramjan or religious fasting cases, I think it will be a reasonable choice. And again, the pioglitazone has some extra benefit. It increases the ovulatory period. So patient taking the pioglitazone, female patient in the reproductive age group should be advised contraceptive measures. And diabetic with the early fatty liver, fatty liver is a common consequence, and we are now very much bothering about fatty liver, NASH, diabetic, hepatic fibrosis, cirrhosis, even lung liver cancer also. So in that aspect, in the early stage, fatty liver pioglitazone has a very potential value. And the incretin effect is also mediated by acarbose and metformin. And these two things, acarbose and metformin, has a salutary effect on the gut flora. The gut flora diabetic is sometimes called an intestinal disease. So favorably change the gut flora, nitrogenous bacteria, etc. So they have some effect on the terminal absorption of glucose. So that is a very important aspect. And Indians have a higher value of DPP4 activity. So DPP4 inhibitor in the Indian scenario is a very effective and good choice. And DPP4 enzymes is also expressed in some cancerous lesion like the lung cancer, prostate cancer, etc. So diabetic with all these cancer will be benefited by the DPP4 inhibitor. And also the CNS system also DPP-4 inhibitor has some role in the prevention or addressing some Alzheimer's or dementia problem. Again, the important one thing is that about the DAPA and the EMPA, the DAPA is now very much highlighted because some input is favorably topping up the DAPA. And your take, and again some data, meta-analysis, particularly published in recent JCM from the SSKM group, that these SGLT2 inhibitors probably may not have any significant role in protection, cardiac or renal protection. And that is the latest data. And pramlintide is another some drug. I don't know whether it is being used in the Indian scenario or not. And what about the status of the glitazole? Because the glitazole, the saroglitazole is very much being tried in the NASH and the diabetic fibrosis. When the hepatic fibrosis, in the NASH, the pioglitazone is not of any value. And there the saroglitazone is very much, and with the hypertriglyceridemia, the saroglitazone has a very important effect. So these are my some important points to add, and then the talk is open for interaction from the house. Somebody is saying there is metformin can be replaced by SGLT2. You have clearly pointed out, no, SGLT2 is not the substitute for metformin. When the metformin intolerance is there, the patient cannot take and because of vitamin B12, etc., then SGLT2 may be used, but SGLT2 is not a substitute for metformin. Now you take up the questions in the chat box. Dr.
Thank you,
Rana,
sir.
please.
Thank you, sir, for your comments. Now there are some questions in the Q&A as well as in the webinar chat. Now let's start with the Q&A section. Dr. Kollan Kumar Bhomik has asked that imeglimin targets fasting or PP blood glucose, and Dr. Arpan Chakraborty has asked that which of these drugs are effective in reduced fasting blood glucose. So I'll take both the questions together. Now see, all the antidiabetic drugs other than possibly the ripaglinide and alpha glucosidase inhibitor, all the other drugs have effect on both fasting as well as postprandial blood glucose level. But they have some preferential action, like the drugs like metformin and to some extent imeglimin possibly is more effective on fasting blood glucose level, but that doesn't mean that they do not act on postprandial blood glucose level. On the other hand, drugs like pioglitazone, drugs like DPP-4 inhibitors, they have a prominent action on postprandial blood glucose level, but they also reduce the fasting blood glucose level. Drugs like GLP-1 analog, they reduce both fasting and postprandial blood glucose level. So for all practical purpose, other than the drugs which specifically targets the postprandial level, like the ripaglinide and alpha glucosidase inhibitor, that is acarbose, voglibose, and meglitol, all the drugs can reduce fasting and postprandial blood glucose level, but again, that varies from one patient to another. Coming to the question which are there in the webinar.